Hi, my name is Peter Ekman. I'm a heart failure cardiologist at the Minneapolis Heart Institute, and I've been asked to speak on hemodynamic support in shock. My disclosures are from Abbott Laboratories, Medtronic, and Daxor. All funds are donated, and I do not control the money. When we're talking about hemodynamic support in shock, I think one of the first factors is who are we likely to see, either in the CCU or the cath lab. Acute on chronic heart failure, ACS, pulmonary embolism are some of the most common settings. I'm not going to talk about cardiac arrest or protocols, as those are covered by other physicians today. Characterizing the hemodynamic need and figuring out whether it's LV, RV, or biventricular failure is important and highlights the role of the Swan-Ganz catheter. I think medications do have a role, and local expertise has a lot to do with the decisions you might make about provision of support. Who's providing it, who gets access and places devices, what do you have on your shelf, and what is available in terms of staff training and availability. This is a framework highlighting some parallels to trauma centers, that not all centers have all modalities, but I think highlights that even in what are characterized as level 3 centers, they should be able to provide diagnosis, chemical support, and at least initial invasive monitoring. The number of centers that have at least level 2 capabilities, where they can provide some form of percutaneous temporary ventricular assist device and perhaps even ECMO cannulation, has certainly growing. This is from a retrospective analysis showing that the use of mechanical circulatory support has been increasing over time, including in the smaller rural hospitals shown in the blue curve. We've seen a concurrent decrease in inpatient mortality over this same time frame, although I hasten to add that this time frame also includes more use of early angiography and percutaneous intervention, so I don't mean to imply that the mechanical support alone is responsible for the improvements. We have also seen trends in PA catheter use. This is a study of the national inpatient sample, almost 1 million patients over a 10-year period with cardiogenic shock. They did have higher cost and length of stay and were more likely to use mechanical support. But in the subgroup with cardiogenic shock, shown in red, there was a benefit in mortality of about 4%, and there was a lower in-hospital arrest rate of an absolute rate of about 3%, certainly providing some support to the use of pulmonary artery catheters in cardiogenic shock patients. I think it tends to be critical in assessing whether this is LV predominant, RV predominant, or biventricular shock. This is some unpublished data from Daveen Kapoor of a number of patients highlighting that a substantial fraction have biventricular failure, at least as defined by filling pressures. Medications certainly have a role, depending on the type of shock. Norepinephrine, dopamine, sometimes even fluids. And for RV failure, inhaled pulmonary vasodilators may have a role. I think it's also important to remember that acute pulmonary edema sometimes can be very well treated and very quickly treated by sublingual nitroglycerin. Not all patients with cardiogenic shock, I would argue, have systolic blood pressure less than 90%, and acute pulmonary edema from hypertensive emergency is arguably another form that we can treat easily. On the left is data from Frank Peacock, an emergency room physician with interest in acute decompensated heart failure, showing that the time to treatment is important, and so cardiogenic shock is certainly something we want to treat briskly. But the figure on the right also highlights the downfalls and the pitfalls of using parenteral therapy, and that medications alone are associated with very poor outcomes, particularly as you add additional inotropes. So I think in many cases these are used to temporize patients while arrangements are made for mechanical support. There was a recent study on temporary mechanical support in the Cardiac Critical Care Trial Network of 16 centers. There was a 2-month snapshot of consecutive admissions. There were 270 patients over this time frame with mechanical support. Acute MI was the biggest fraction, although cardiogenic shock, presumably from acute decompensated heart failure, was very comparable. There was some with mixed shock and some with another indication. It was interesting that there was substantial variation between centers in the amount of use and the type of use, and that's shown here. On the left, you can see one center used temporary mechanical support devices in 17%, and another used it in about half. You can also see on the right, the type of shock determines a little bit what modality is used, and I think you can appreciate that balloon pump remains the dominant modality in most cases, at least in this network, although the use of Impella in acute MI has increased substantially, and modest fraction of ECMO use in the cardiogenic shock without MI. Which device to use? That depends what needs support, how much support is needed, the severity and the amount of flow or support you can get from a device is an important consideration. If you need pulmonary support or oxygenation, that's a setting in which most would be inclined to move to ECMO sooner rather than later. Keeping in mind potential contraindications, ECMO needs large bore access, you can't put Impella across a mechanical aortic valve, and a balloon pump isn't as effective if you're very tachycardic. Aortic dissection and or regurgitation is a particular challenge for most of these devices, and I think the decision of which device to use often comes down to local factors. So I didn't want to spend a lot of time today discussing the specific details of the different specific devices. Those that are interested can find a lot of information on that from other sources. There has been some effort to answer the question of which device. The IMPRESS trial was a randomized multi-center trial, although it was very small size, but sick patients, looking at balloon pump versus percutaneous VAD. There was no difference in all-cause mortality, which I think remains a challenge to the field, that we still struggle with what's the right option and when's the right time to deploy it. As a chronic heart failure specialist, this was data I thought was valuable from Columbia, looking at the use of a balloon pump for cardiogenic shock. These were patients that had generally chronic heart failure and had failed to bridge to discharge on medical therapy. And they were supported with a mean increase in cardiac output of about a half a liter. PA pressure went down, mean arterial pressure went down a little bit, but they had, importantly, a 30-day survival of 84%, and ischemic cardiomyopathy and low PAPI were predictors of deterioration. These patients were comparable to the patients in the shock trial, which was an acute MI trial, in terms of their cardiac power index, but the mortality was much lower, suggesting that chronic heart failure patients may respond somewhat differently. They also found that there are some patients that are super responders, and the higher mean pulmonary artery pressure was predictive of that. Another recent publication trying to estimate differences between a balloon pump and percutaneous device studied a balloon pump versus Impella with a propensity-matched analysis from the Cath PCI and chest pain MI registries, and they found 1,680 propensity-matched pairs, and they found higher rates of death and in-hospital major bleeding. This is obviously subject to the number of problems with retrospective analysis and propensity matching, so the jury is certainly still out on this, and I think there's room for more data in this space. When making these decisions, there are other factors to consider. I think patients that are being considered for mechanical circulatory support are certainly at risk for bleeding from arterial access, limb ischemia, and these are patients that often will have secondary organ failure from their underlying problem. The next step is, of course, I think, as someone who takes care of a lot of patients in the CCU, just as important, what happens when you leave the CV lab? I would put in a plug for continued hemodynamic monitoring and the importance of a pulmonary artery catheter in evaluating these patients, developing an experienced team, and as a cardiologist who practices at a center that includes ventricular assist device and transplant, I can speak from experience that we would rather know about and be involved in the care of these patients early rather than on day 5 when we've been unable to wean support. The evaluation for durable therapies can take some time, and it's helpful for the team to get to know the patient and family. I appreciate the opportunity to speak today and would be happy to connect offline if anyone would like to discuss this topic further. Thank you, and I hope you enjoy the rest of the conference.